Okay, everybody, today we are going to kind of continue with the nervous system in a way, in that this lecture on special senses is a bit of a specific portion of our nervous system. And so let's get started. All right. So before we talk about the special senses themselves, we somewhat have to determine what our general senses are, because we can't have special senses unless we have general senses. So a majority of these stimuli and receptors here on our first couple of columns go with our general senses. This one up top, light and photoreceptor, goes more with the eye and special senses. And what you will end up seeing is that general senses are the senses that we can sense anywhere. That's why we call them general. They're all over the body. An example of this would be pressure or pain. So, no matter where you touch on your skin, assuming all your nerves are functioning fully, then you can feel pressure or pain, and temperature is another example of that. Chemical can be a little bit different in terms of our chemoreceptors. That is a general sense in some, because it's not just in one or two organs, but it's also something that we'll talk about with a couple of our different special senses. And as I said, light is another example of a receptor that we find in our special senses. So the thing that makes our special senses special is that they have very specialized receptors that are found only in specific areas of the body. So, for example, the photoreceptors that we have, our rods and cones, are found on the retina of the eye. We don't have photoreceptors in our skin, that we have them in our eyes. Chemical stimulus and chemoreceptors will associate with taste, you can see here, as well as with smell. A couple of our other special senses, so we have sight, taste, smell, hearing, and balance or equilibrium. And so both hearing and our equilibrium or vestibular system are housed within our inner ear. So, just to kind of circle back towards our nervous system lecture, this is kind of a reminder of how our body perceives, or sensory perception occurs. So, remember, it has to start in the periphery. So, we have to actually have a stimulus occur first. So, these in this first column are examples of stimuli. And you'll see that our different types of stimuli have their own specific type of receptor that is special for that stimulus. So for light, we have photoreceptors. For chemicals, we have chemoreceptors. For pressure, we have mechanoreceptors. At the very end of this lecture, you'll see a group of mechanoreceptors, and we'll talk about their individual jobs because that's kind of an umbrella category. Pain, we have nociceptors. And so another term for pain is nociception. So if you kind of took this beginning of our receptor word, nociceptor, got rid of the OR and added ION, we would call that nociception. So pain, or the perception of pain, is nociception. That is perceived, or the receptor is a nociceptor. Temperature is a thermoreceptor. So think like a thermometer, but it's a thermoreceptor. So initially, we get a stimulus. One of these categories, oftentimes, we're going to have multiple of these categories that are kind of crossing and sending info to the brain at the same time. So the stimulus is applied, its specialized receptor receives that information. In this example here, it's talking about the ear or the eye. Obviously, that can occur in many different areas. That's just one example. So the receptors within the target area, wherever that stimulus applies, is going to then excite different nerve fibers that are going to ascend with afferent information. Remember, ascend and afferent, is going to carry that sensory information up to the brain. And so this is just a reminder that different portions of the brain are responsible for, or more responsible for certain stimuli or sensations. So we talked about the parietal lobe having our somatosensory cortex, that post-central gyrus or ridge, but these are some other examples of the brain that interpret some of the information that come from our different receptors. And then remember, we talked about the second half of this as well. Once the brain makes a decision on what needs to happen, it's going to send efferent information or motor impulses. We said efferent exits, and that's going to go down our descending tracts with a T. So this shows how we perceive the stimulus, and then the brain would interpret it and decide if there's any action that needs to happen because of the stimulus. So this kind of diagram or flow here applies to both our general senses and our special senses. Like I said, the difference between general and special is that general can be felt all over. So that can be pressure, pain, touch, temperature, vibration. Itchiness is another example that you may see that you don't see quite as often, but you can get itchy anywhere. So think something that you can sense anywhere in the body, then it's going to be a general sense. Our special senses that we'll focus on in this lecture all have their own kind of special home that has the special receptors. Okay, so the first one we'll talk about is taste. So to do that, we'll start by talking about parts of the tongue. So we've seen this term papillae a couple times. So anytime in the body we find these little hills, we call them papillae. So in the small intestine to help absorption, we had papillae. In the integumentary system chapter, the dermis and epidermis fit together like a puzzle piece because of the dermal papillae. So papillae always mean hills or little bumps. So when you look at your tongue and you see those bumps, you're looking at the papillae. And so each papillae contains a bunch of different taste buds. So our taste buds are a chemoreceptor. So they are chemical receptors that stimulate nerve fibers, and that our brain interprets those as different tastes. So there's 5 different types of tastes that you can feel. You get salty, sweet, bitter, sour, and another one called umami. So umami is like an earthy taste. So some examples of umami may be like mushrooms or soy sauce or miso, some of those examples, if you're curious what the word umami is. So this is like a zoom in on the tongue. So that's the papillae themselves. And then if we go all the way microscopic zoomed in, we can see the individual taste buds. So taste buds can taste all those 5 senses, but they're more sensitive or have more cells that are sensitive to one taste versus the other. So if you look up, for example, like a tongue taste map, it'll show you that you can probably taste sour better on one part, bitter better on another part, sweet better on a certain part, because that region has taste buds that are more sensitive to those tastes. So that may be just kind of like a fun experiment for you. So in terms of the tongue itself, remember, it's just a really strong muscle. One of the ways we can test how the tongue is functioning and how our 12th cranial nerve is functioning is by making sure we can move our tongue up, down, left, right, and that it's symmetrical. So the hypoglossal nerve, that number 12 on our chart from last lecture, goes with our tongue. So we call the tip of our tongue the apex, and we call the kind of larger part or majority of the tongue the body. The sulcus terminalis is kind of just the drop off directly after the tongue. And then if you put your tongue on the roof of your mouth, if you remember all the way back to the skeletal system chapter, your hard palate is the hard part of the roof of your mouth. That's formed by your palatine bones. If you go farther back, we hit our soft palate, which is really a muscular layer. And so the sulcus terminalis and the soft palate, along with the tongue, they help us to stimulate our swallowing reflex. So once food gets far enough back in the mouth, that sulcus terminalis, the soft palate, and the tongue will automatically help us to push that into the pharynx and eventually to the esophagus. Speaking of the esophagus, don't forget the epiglottis. So remember, that blocks off the larynx and trachea. And so food is going to enter into the pharynx and then the esophagus. We don't want it to go into the larynx and trachea because that's respiratory, not digestive. The other two things to point out here that are not really parts of the tongue, but really parts of our lymphatic system are the tonsils. So our tonsils are really masses of lymphatic tissue, and they're kind of our security checkpoints. Of course, we breathe through our mouth, we're eating things, things get into our mouths. So we want to have some kind of defense system or checkpoint that can try to get rid of some debris and unwanted visitors before it actually enters the body. So you have lingual tonsils, you have palatine tonsils, and you actually have a third set of tonsils that are not shown here. But the palatine tonsils is really what I wanted to highlight because if you have chronic tonsillitis, which is inflammation of the tonsils, you'll see that on our next slide, then oftentimes those are the tonsils that are surgically removed. And part of the reason why it's okay to remove the tonsils is, of course, if you have a fully functioning immune system, then you have plenty of checkpoints throughout the body, even if something does get in. And like I said, we have two other sets of tonsils that will do the same job as our palatine tonsils, even if they're removed. So the technical or science term for taste is gustation. Gustation. So taste is kind of the common man term. Gustation is our fancy term for taste. Okay, like I said, tonsillitis is something that is very common, and so that we've seen our suffix itis plenty of times now. So we have inflammation of the tonsils. If we said pharyngotonsillitis, that would be our tonsils and throat. Remember, our pharynx is the one part that was respiratory and digestive, so we consider that kind of the back of the throat. If we just said pharyngitis, that would just be a sore throat, not inflammation of the tonsils, just a sore throat. And then this term ageusia is the inability to taste. It's kind of like a mixture of some of our terms. So we know our suffix ia is a condition. A means with or sorry, without. And goose here is for gustation. Like we said, that's our fancy term for taste. So without a condition, without taste. Inability to taste is ageusia. Okay, so the next one we're going to talk about is smell. And before we get into the actual sense, I just want to go over what our actual parts are for our nose. So we said the nose is part of the respiratory system for the most part, but part of that is smell. So remember, we have these sinuses. They're in a few different areas, and they kind of work hand in hand with these turbinates. So turbinate is really, you can think of it just as like an indent or a little cave. And so when we breathe in our air, it's not necessarily ready for the body, or it's not the same as our body's environment. So between the sinuses, which are just extra space, and the turbinates, we have space for our air to be able to humidify and warm up so that it's kind of homeostatic with the body before it goes all the way into our respiratory system. I always use the example of if you like to run or are exercising on a cold day, oftentimes when you're running and you start breathing through your mouth instead of your nose, then you're kind of sucking in cold air, and oftentimes it gives you that burn in your lungs and your chest. So remember, we have two different roots for nose. We have nase/o and rhine, RHIN/o. So naso or rhino. The nasal vestibule is that kind of drop off between the nose and the upper lip. And then remember, our nostrils themselves are the nares, Nares, nares. And then the cartilage that divides our nares and our nose is called your septum. So like I said, these turbinates and the sinus, and like I said, there's a few more that aren't pictured here. These are just to warm and humidify the air. A couple of other points that are highlighted here, the eustachian tube orifice. So our nose, and really kind of the back of the nose, the nasopharynx, has an opening for where our ear tube or auditory canal travels. And so that's how we equalize pressure between our ears and our nasal sinuses. And we'll see the kind of the other end of that structure when we talk about the ear. This fossa of Roland-Muller, it's on the diagram that we're using. It's really not a super important point for you guys in terms of anatomy, unless you're going into the nursing or oncology field. The fossa of Rosenmuller is an important point because it's another little kind of like cutout or cavern like our middle turbinate. And so it's or really all of our turbinates, but it's a very common spot to get cancer, likely because when we have someone who's a smoker and they end up breathing in fumes or breathing in smoke, that is going to kind of sit in those turbinates or that fossa. And so those cells get exposed to more of the carcinogens than some of the other cells. So that's a special place to look for a certain type of cancer. Okay, this is a good chance to pause your recording for a second and then don't go to the next slide quite yet. We'll go over, see if you can kind of define these words, and then I'm going to talk to you about the process of smelling, and olfaction is our fancy term for smell, and then we'll pop to the next slide and take a look at our answers. Okay, so hopefully you have your answers down now. So we're not going to get into the nitty-gritty details. We're going to go through these four basic steps. So again, we're dealing with chemoreceptors when we're talking about our sense of smell. I just said our sense of smell is also known as olfaction. And so if you remember that smell is called olfaction, you can remember that the nerve that is responsible for smell is the olfactory nerve. So that is another one of our cranial nerves. So you really should at least just kind of know the cranial nerves associated with our special senses. You don't necessarily have to memorize 1 through 12, as I said before, but you should definitely know these ones that we talk about in our special senses lecture today. So from this cranial nerve, we have olfactory receptors, or what we call olfactory bulbs, that drop down from the olfactory nerve into the nasal sinus. And so these olfactory bulbs or receptors are chemoreceptors that interpret the different chemicals that we breathe in as different smells. And this goes up, you can see it goes kind of towards our thalamus and hypothalamus, our diencephalon. It's also closely linked with a structure known as our limbic system, which is kind of our emotional system or regulatory system in the brain. So that's why smell and emotion are very, very linked. So we get the chemicals landing on our olfactory bulbs or receptors. That then travels kind of up as an action potential to our olfactory nerve. And now it's going to carry its signals to our diencephalon and other centers in the brain. So if you haven't yet, make sure you try to get your definitions down using your new list. So remember, there's one for the nervous system and one for special senses, and then go ahead to the next slide when you're ready. All right, so check your work there. Most of them are pretty much straight definition. A couple that were not really word building. Like I said, olfaction is our sense of smell. And then nosebleed doesn't really translate directly. We don't call it a nasostaxis. Remember, staxis is dripping. So hemostaxis would be dripping blood. The term is epistaxis. Epi, remember, is above or on top of. So think of kind of your nose and the nosebleed coming from above and dripping down to help you remember that it's epistaxis. That's on your additional terms. Okay, moving on to the hearing part of things. So we're going to talk about the actual sound hearing. I said there's one other special sense housed in the ears, and we're going to kind of ignore that one for now and just talk about the hearing aspect. So we break the ear down into three different sections. We have outer, middle, and inner. And these words that are, oops, sorry guys, these words that are above outer, middle, and inner, it's going nuts on me. Okay. These words above outer, middle, and inner describe the main job of that segment of the ear. So the outer ear's job is just to kind of catch and focus sound to send it to the middle and inner ear. So we have two different parts of the outer ear. We have the auricle, auricle. The auricle is this fleshy lobe part of our ear. And then we have our ear canal or external auditory canal that acts as our actual kind of tunnel or canal to the eardrum and the rest of the inner ear. Another word for a canal in the body is a meatus. So sometimes, if you're looking, depending on what source you're looking at, you may see the term ear meatus or external auditory meatus. So don't let that throw you off. So the kind of the proper term is the external auditory meatus or the external auditory canal. So the outer ear and middle ear are divided by this important structure, which is our eardrum. Another word for the eardrum is the tympanic membrane, Tympanic, the tympanic membrane. And so as sound is funneled into the external auditory canal by the auricle of our ear, it travels and it hits our eardrum or tympanic membrane. And so that causes our eardrum to vibrate. And so that vibration is now going to pass to our middle ear. So the middle ear has our three tiny bones, the three ossicles of the ear. So these are the littlest bones in the body. And their job is just to pass vibration from our eardrum through its bones to our inner ear. So our three bones here are called the malleus, the incus, and the stapes. And you can kind of see our stapes ends in this oval shape, and we call that the oval window. The oval window. And that is how that vibration from the middle ear is going to travel further into the inner ear is through the oval window. So the middle ear just is a middleman in a sense. It detects the vibration of the eardrum and then passes and transmits that vibration through the three bones to the inner ear. So the malleus, the incus, and the stapes are our three little ossicles of the ear. Okay, so our inner ear we can sometimes refer to as the neural portion of the ear because this is where hearing actually is converted to neural signals that we can interpret as sound. So this snail shell looking organ here is our cochlea. So the cochlea is our hearing organ. This is where hearing is actually, those nerve impulses are actually generated. So I said the inner ear is responsible for two jobs. So this part, this snail shell part, is the cochlea. It's responsible for, like I said, generating nerve impulses related to sound. And then this other half, our vestibule, ampulla, and semicircular canals, they go with the vestibular half. So you can see we have a nerve that's dedicated to our cochlea, or half of the nerve, and then the other half is dedicated to this back half. So that's our other cranial nerve, or one of our other cranial nerves called the vestibulocochlear nerve. So it has a vestibular half that we'll talk about later on, and it has a cochlear half that is in charge of creating our nerve impulses due to sound. Okay. The only other structure I haven't pointed out yet, I said we would see the other half of our eustachian tube. So that was what we saw as an opening in the nasopharynx. This is the ear portion of this eustachian tube. And let me go back just for 1 second, actually. So I don't want to leave you guys hanging. I'm not going to go into depth on how hearing occurs, but I don't want to just kind of pretend that that vibration goes into this snail shell and we just magically get nerve impulses. So let me just kind of give you a quick rundown. So the stapes is the last ossicle in the chain. It vibrates on the oval window. Our cochlea, this snail shell structure, has two different what we call labyrinths inside. So if you know what a labyrinth is, it's kind of like a crazy maze type structure. Think of like a hedge maze or a corn maze, or like labyrinths in the pyramids, or where that word kind of comes from. It's like a maze. So these two labyrinths have fluid in both of them. And so when that vibration goes, it vibrates the membranes and the fluid within those labyrinths. Those cause little hairs within the cochlea to bend certain directions and be stimulated. And so that ends up resulting in a generation of a nerve impulse. So it's really the vibration of the eardrum to the vibration of the three ossicles that causes movement of fluid and membranes within the cochlea that bends hair cells that generate nerve impulses. And so, depending on the direction they're bent and the size of the hair cell that is bent, we send signals about volume of sound as well as pitch of sound. And so our higher pitched hair cells, the ones that determine the really high pitches, those are the most fragile and kind of degenerate the quickest, which is typically why for older adults that have some hearing loss, it's the high pitched sounds that are lost first. Okay, this just gives you guys another chance to practice. So don't go ahead yet because you'll see all the answers. That's cheating. And just go ahead and pause your video. Try to use your new list to define your words, get some practice, and then we'll go on and highlight a couple things. Okay, so you'll see your first two answers should have been the same, but we have two different roots for the word ear. And then we know our suffix algia is pain, or dynia is the other suffix we've seen for pain. Acusis is a new suffix for us for hearing. Acusia is another suffix that can mean hearing, but remember our suffix ia by itself is a condition of. So cusis means hearing. Acusia is typically used for a condition related to hearing. So putting hearing is a fine definition, but that's kind of the difference between our two suffixes if you really want to try to kind of be picky. So acusia, just like emia was for a blood condition, acusia is kind of like a hearing condition. Remember, this is where the hearing happens. There's that word labyrinth. That was partly why I wanted to tell you guys about the labyrinths, or the structures within the cochlea, because that gives you some context for where that word root comes from. So that's what it's referring to, is the labyrinths inside of the cochlea. Otitis here, otitis media, is probably on your additional terms list. And so otitis media is an ear infection. And then sometimes ear infections can result in some fluid or ear fluid that builds up. And we'll talk about how that can cause an ear infection and the difference between adults' ears and kids' ears in a little bit. This bottom one, meringue here, that's a little bit of a less intuitive one to remember. That means eardrum. I think sometimes if you think about ringing something, the eardrum would vibrate or ring when you hear sound. So that's one way you can try to remember that. Okay, so why are kids, or babies and infants especially, more prone to otitis media? That's the kind of fancy term for an ear infection. So take a second and look at the two pictures and tell me what you think or what you notice as a difference between the eustachian tube. So I'll give you a hint. All the structures themselves are the same. There's nothing that's there or not there in the adult or infant that's different than the other picture. It's more of the way our structures are put together. Okay, so if you notice The infant's eustachian tube towards the nose is a bit more horizontal than the adult's. The adult's is a bit more on a diagonal. I wouldn't say vertical, but a bit more of a diagonal than the infant. So if we get fluid in the ear, it can drain via our nasopharynx kind of area, the nasal sinuses. For kids, since it's more horizontal, gravity has a tougher time helping us drain that tube, and therefore there's a higher chance that it's going to sit there and cause irritation. So that's kind of a reason they put tubes in for kids that get chronic ear infections. They may have even more of a horizontal or narrow tube than other kids. Okay, just another kind of more oral terms. So remember AURAL, not to be confused with oral, ORAL, which would be the mouth, or AUR is going to be the ear. So the acoustic neuroma. So this is a tumor oma on the nerve or the acoustic, the sound portion of our vestibulocochlear nerve. So this is that tumor growing on our vestibular nerve. Proprioception. So the term proprioception means kind of be able to sense where you are in space. So joints have proprioception as a general sense. So if you were to close your eyes and raise your right hand, you can probably raise your left hand in the same spot without looking. That's joint proprioception. The proprioception itself is more of a general sense, but equilibrium and balance and vestibular system, our ability to focus our eyes and our heads as we're moving, is a special sense. And so you can see our snail shell again. That's the cochlea. So we're going to ignore that part now. That's the hearing part. We have these other structures, the ampulla, the cupula in the vestibule, and then our semicircular canals. And so we're not going to get very into depth with this. There's a lot of detail that we could go into in terms of exactly how this system works, but we're going to keep it very surface level. So more or less, just like in the cochlea, there is fluid within these semicircular canals that causes movement of hair cells and different parts of these membranes. And so as we turn our heads or look up and down or move around, this fluid moves that kind of tells our brain where our head is positioned, and it also is very closely connected with where our vision and gaze is focused. So we have kind of two different types of equilibrium. One of them we call static equilibrium. And so when I always use the kind of the trick S for static, S for straight. So when you're walking in a straight line and you're kind of looking up or looking down, your static equilibrium system, which is housed down here, in this portion, is going to tell you, based on how gravity is moving the fluid, where your head is positioned. And even if you're looking up and down, you can kind of still keep on that straight track. The other side of things is dynamic equilibrium, which is related to rotation. So when you're turning your head back and forth, nodding no, or think of a more real life example, or a more functional example where you're walking in the park and you're looking at all the trees and birds. When you're driving in the car and you're checking your right and left while you're still trying to drive straight down the road. That's more of a dynamic equilibrium. And so our semicircular canals here, in response to rotation, or the fluid within them moves in response to rotation. And so it's our way to be able to keep our gaze focused or keep our orientation even as our heads are moving, and sometimes our eyes are either staying still or moving with it. So one way you can kind of test this system is if you hold your thumb out about eye level straight in front of you. Put your arm all the way out straight and focus on the very tip of your thumbnail and start slowly moving your head right and left as far as you can, um, and stay focused with your eyes on that tip of your thumbnail. So if you do it slow, it's pretty easy. If you do it fast, then it gets much more difficult, and that tests your vestibular ocular reflex some. So it tests your vestibular system, or these semicircular canals that are in charge of maintaining equilibrium. And so you can see that the faster you turn your head, the harder it is for your eyes to be able to keep up and stay focused. So static equilibrium is more gravity related. It's just kind of staying straight planes. Where's my head positioned? Dynamic equilibrium, think rotation. This term tinnitus is a pretty common term to see. It means ringing in the ears. So there's two different types. You really don't need to know this. It's more nice to know. There's subjective tinnitus, where kind of random ringing nerve impulses are sent off and we don't really know why. And there's objective tinnitus that is actually caused by a structure such as a tumor or a virus that's causing that nerve impulse to say that you hear ringing. So that's just what that word tinnitus means, is ringing. Okay, we're getting there. Parts of the eye. So our parts of the eye actually has a decent amount of parts. So it's kind of easy to tell where everything's pointing to, but the way that the words are organized are more so that they don't overlap with each other. It's not necessarily grouped together by certain segments. So I want you to pay attention to the way that I am going to talk about it, because we're going to go from superficial, or the outer portion of the eye, and then end up in the deepest portion of the eye as we go through our structures. So the eye really has three layers. And so we're going to talk about those three layers from superficial to deep, which means from the outer layer to the inner layer, if you remember all the way back from the very beginning of the semester. Okay, so the first two structures we're going to talk about are the sclera and the cornea. So the sclera is the white portion of the eye. So it makes up a majority of that outer layer. So it's the white portion of the eye. It's really just there to protect the structures underneath. The other part that is the outer portion, this whitish tan, is the cornea. So your cornea is transparent because it covers the front of the eye. So we have to be able to let in light. So we don't want white on the front of our eye as well. So the cornea is just covering the anterior portion. It's the transparent structure. So those are the only two parts of that outer layer. So the sclera and the cornea make up our fibrous layer, or sometimes you'll see the word fibrous tunic. So you don't need to know that. That's just kind of a nice to know, or you may see that if you're in anatomy right now as well. So our next layer, we're going to go from the front of the eye. So our next layer is the vascular tunic. So we'll talk about why we call it the vascular tunic, but we're going to get into the eye from front to back. So we're going to start here. So we said the cornea is part of the fibrous layer. It's the transparent protection for the front of the eye. Right behind the cornea, we have our iris and our pupil. So the iris is the colored portion of your eye, and really it's a muscle. And so the pupil is the black center of the eye. It's not really as much of a structure as it is more of a window. The pupil's job is to allow light into the eye, and the job of the iris is to make the pupil wider or dilated, or constrict it, make it smaller. So if we have a lot of light available, we can make our pupil smaller so that we don't let too much in. But if we are in the dark and we don't have a lot of light available, our pupils will dilate because we want to let as much light in as possible. So like I said, the iris is the colored portion. It's a muscle. And then the pupil is the window that allows light into the eye, and it adjusts to allow a certain amount of light to make it kind of ideal conditions for vision. The next structure we hit that's still in that layer is the lens. So the lens's job is to focus light onto our retina, that we'll talk about in our kind of final layer. So anytime you hear of a lens, it is going to be to focus light onto the retina. So the way kind of light passes in, it travels through that transparent cornea. The iris controls how big the pupil is to let a certain amount of light into the eye that then hits the lens to focus it onto our retina. And then this thick red layer here is the reason we call it the vascular tunic. So remember, the word vascular means it's got a good blood supply, and that's provided by our choroid plexus. So the choroid plexus is represented by this thick red layer. It supplies blood and nutrients to the eye and especially to the retina, which is our deepest structure. That's the choroid plexus. The only other thing to point out about the choroid plexus is that it contains melanin, so that it has a darker pigment, and that way we don't have light reflecting off the back of the eye and causing a glare for our vision. So we kind of have built-in tint. The only other structure that I haven't pointed out yet that's kind of still associated with these structures in the front is the ciliary body. And that's a muscle that attaches to the lens and it changes the shape of the lens. So the lens has to change shape so that we can focus the image that we want to see or the light that we're seeing directly onto the retina. So think if I'm looking at something off to my left, but I still want to focus it into the center of my retina, I have to be able to kind of bend that light image to do that. So that's the lens's job. So in our final layer, the deepest layer is the neural layer, which is primarily the retina. So that's this yellow structure in the back of the eye. And so our retina contains the photoreceptors. So we mentioned our photoreceptors or our light receptors way back in the beginning. And so we have two different types. We have rods and we have cones. So the thing to remember is C for cone, C for color. So our cones are the color and our detail vision. So they can only see in red, blue, and green, or at least that's how they're stimulated, is red, blue, or green light. And the combinations of that red, blue, and green are what make all the different colors that we know we can see throughout our lives. So if you've ever messed with like a computer and you're trying to pick a custom color, it'll give you 3 sliders for red, green, and blue. So that's why it's the combination of those colors that make up every single color that we see. The rods, on the other hand, are our dim light vision, and they're not necessarily good at detail. They're kind of more big picture structure. And so we have a lot more rods than we have cones, but our rods are nowhere near as good at seeing color. They don't see color at all, and they're nowhere near as good at seeing detail. So if I'm trying to focus and look at something and really check out the detail, I'm using my cones, not my rods. If it's pitch black and I'm trying to see the best I can, my rods are the ones hard at work. Other structures to point out here. We have our optic nerve. That's another cranial nerve that you should know. The optic nerve that's responsible for vision. And we also have blood vessels that are entering the eye to supply some of our other structures. And so the spot where these enter, our optic nerve and the vessels, we call that the optic disc. The optic disc is where the optic nerve and the optic blood vessels enter. And so because we're entering and exiting in terms of our nerve and vessels, we can't have rods and cones directly on that spot. So we also call that the blind spot right here where it enters the retina because we have no photoreceptors there. A couple other terms that I want to point out in relation to the retina are the macula and the fovea centralis. So I already said our rods are not as good at detail. They do black and white. Our cones are very good at color and detail vision. And so our cones, or we have cones that are concentrated at the center of our retina, or pretty close to the center. And that area is called the macula. That's where our best vision is. I kind of describe it as, think of that as a dartboard. That's the target for our light when we're trying to see something clearly. Now, within the macula, within our dartboard, we have a bullseye called the fovea centralis that only has cones, and that's where our best, like 100% vision is going to be contained, is the fovea centralis. Our number one magnifying glass and best detail is the fovea centralis. So the macula is kind of the dartboard. It's got our best vision, and the fovea centralis is the bullseye of that dartboard where we have our top vision. One other last term that we haven't hit yet is the vitreous humor, and it has a partner called the aqueous humor, Aqueous, aqueous. So we're not going to get too much into detail in terms of the different breakdown in terms of anatomy of the eye, other than the parts, but we can separate our eye into a few different chambers. So we have the front of the eye, the anterior chamber, and the back of the eye, the posterior chamber. And really, if we want to get super detailed, the front of the eye has two chambers, and the back of the eye is its own big chamber. But we're not going to complicate it that much. So I want you to just remember anterior of the eye, the front of the eye has aqueous humor. So think for a second about what that word aqueous sounds like. So the word aqueous to me sounds very similar to aqua. So think aqueous is going to be the watery substance. And so this is transparent. It lets light in because remember that front half of the eye needs to let light in so that it can focus it to the retina. And it just kind of helps keep a little bit of pressure for the eye's structure and to help keep things in place. And then our vitreous humor is in the back chamber, the posterior chamber. It's more of a jelly substance than a watery substance, and it's really helping to hold the retina in place and the front half, the lens and other structures in place. The lens is kind of what we use as our border from the anterior and posterior. So that's what the vitreous humor is. It helps maintain pressure and keep things in place, but it is transparent enough to still allow light through, even though it's more of a gel compared to our aqueous humor, which is very watery. All right, another chance to practice here. So go ahead and pause your lecture. Try to use your new list or go off memory the best you can for the terms that you have seen before. And then when you're ready, go ahead and start back up and we'll go over it. Hmm, Forgot I didn't give you guys an answer slide on that one. Okay, so let's go over it together. A scleroscope. So we just talked about the sclera being the white portion of the eye, and a scope is an instrument used for visual examination. So a scleroscope would be an instrument used for visual examination of the sclera. So remember, a scope is used to perform a scopy. So scleroscope would be used to perform a scleroscopy, which is the actual process of visual examination. Blepharoptosis. So this suffix we've had on at least one or two lists, and it means drooping. Blepher slash O is our combining form for the eyelid. So blepharoptosis would be a drooping eyelid. Choroidosis. This is the choroid plexus. So that one's an easy one to remember. We just talked about that being the vascular supply for our retina. And then osis is abnormal condition. And really, we should be starting with our suffix when we're saying the definition. So this would be an abnormal condition of the choroid. Choriotomy. Remember, tomy is incision or to cut into. Ectomy is excision or to surgically remove. And then core is for pupil. That one's for pupil. So I think core, pupil is the center of the eye. Conjunctivitis. So this is on your list, of course, but it's not something that we've talked about quite yet. So itis we know is inflammation. Conjunctive slash O would be your combining form for conjunctiva. That is the lining of your eyelids. So this right here is your conjunctiva. So conjunctivitis is when this eye lining gets irritated. Phacopathy. So Raphy is for suture, and then PHAK slash O, fac slash O is for lens. So I don't have a good trick for that one. That's kind of a weird one. Retinoma would be a tumor on the retina. You can see we have a bit of a mass growing here. Remember, the retina is our deepest neural layer that has our rods and cones. Keratoconjunctivitis. So I put this one on here primarily because This word kerata we've seen before in integumentary system for keratin, that structure that makes our skin tough and hardens our nails and hair. And then we just had this word above, so we know that's the lining. So keratoconjunctivitis, and when we're talking about it in relation to the eye, is going to mean the cornea. So kerato is cornea, and then we just talked about conjunctivitis being inflammation of the inner lining. So this is the term for dry eye. So this is the term for chronic, like the diagnosis of having a dry eye or irritated eye. Iriditis. So for the iris, we switch our S for a D. And so that would be inflammation of the iris or the colored portion of the eye. Aniscoria is more of an additional term, but it's kind of a build a word in a sense. It's shown by this picture in the top right here. You see her right pupil is very dilated. Her left pupil is very constricted. That is very abnormal. You want to see that pupils are equal, and so they should react or widen and constrict the same based on light exposure. Even if you're only exposing one eye at a time, they're supposed to work as a team. So aniscoria, so IA condition, core for our pupil, and means without, and ice O, if we had an O there really, is for the same. So it's kind of a blend. So that's without the same pupil. So two pupils of different sizes is aniscoria. And then lastly, scleritis. That's a really easy one. Sclera and itis, so inflammation of the sclera. Okay, here's some more practice. This uses more of the additional terms than it does just your list. You can kind of use your list to help you some, but go ahead and take a look at these. And then when you're ready, go ahead and hit play and go to the next slide. Okay, so glaucoma is a super common diagnosis with vision loss. So, and that's an increase in intraocular pressure. That's what IOP means, is intraocular pressure. And so we talked about the aqueous humor and vitreous humor providing some pressure and structure to the eye. So a little bit is a good thing. There's a normal level that we need to keep our structures in place. But if that level goes too high, it begins to damage structures and that can lead to blindness. So most glaucoma diagnoses are very slow progressing. There's a couple forms that can be rapidly progressing that they have to address immediately or can lead to complete blindness. Hemenopsia is loss of vision in half of our field of view. So it's a weird one. So it's usually either you lose the right half of vision in one or both eyes or the left half of vision in one or both eyes. Not necessarily top or bottom, but that can happen as well. Hyperopia and myopia are our terms for farsightedness and nearsightedness. So that's the two different types of vision. So you can have glasses for needing to see close to you because you have no problem seeing far away, or you need glasses for farther away, but you have no problem seeing close to you. Presbyopia is the term we use for kind of vision loss that we associate with being kind of attributed to old age or the aging process. So just like we said, the hair cells in the ear degenerate. Same thing with some of our photoreceptors in the eye or our retina and different structures in the eye. They will degenerate just as we get older as part of the normal aging process. And optometry would be the process of measuring vision. So optometry is what we refer to as kind of the eye doctor, and optometry is the process of actually measuring our vision. All right, I said in the very beginning that we would circle back to our mechanoreceptors. So this is just something that you should be able to pick out in terms of a matching question. So Meissner we'll see on the next slide, but it's very similar to the Pacinian corpuscle. So they sense pressure, but they also sense vibration, and that's what makes these two things more different. So the Pacinian corpuscle gets high frequency vibrations, high frequency. Our Meissner, you'll see, does low frequency vibrations. So that's really the only difference between those two. Our Ruffini organ is more of a stretch of the skin and also a bit of a temperature receptor. It also can sense temperature. Merkel discs, this is our most sensitive one for light touch. And then our free nerve endings are other temperature receptors that we find. So I know it's a little weird to see the term temperature in here. We call them mechanoreceptors, even though they can sense temperature, because thermoreceptors purely detect temperature. This is more of a temperature in a sense of it being related to physical touch at the same time. So our free nerve endings and Ruffini organs are really thermoreceptors that are related to when something touches us, whereas thermoreceptors in the body are going to just measure temperature like a thermometer would. I just wanted to clear that up. And then, like I said, Meissner corpuscles, fine touch, pressure like the proscenians, but these are low frequency vibration or flutter. They're very, very sensitive. So it doesn't take much touch or vibration to trigger a Meissner corpuscle. So just kind of know those definitions. But the ones that are harder to keep track of are Meissner versus Pacini. Free nerve endings is going to be your one that you associate with temperature. For Ruffini, I would kind of keep this stretch word in mind rather than warmth so you don't get these two confused. All right, I know both these chapters were kind of heavy ones, but I hope that was helpful, and keep studying your word lists and have a great day.